Hi everyone, my name's Aisha. I'm a dual qualified foundation doctor and I'm the OMFS Survival Guide Programme Lead. This talks on facial trauma, basically how to take a history, assess a patient, and some important things to look for on the imaging. So the aims for this talk are to give you an overview of a systematic trauma examination, to help you understand the pathophysiology behind certain signs, and to understand which cases might need further investigations or management by another team as well. We also want you to be able to understand some important signs of head and C-spine injury. So we're going to move into the first case, and we have Elena, who's a 37-year-old female who's been referred by A&E after being punched, and she has a fractured mandible. They'd like you to have a little look at the radiographs. They tell you that she's fit and well, doesn't take any medications, and she has no allergies, but she still seems drunk. So have a little bit of a think about what else you'd like to ask over the phone, because this isn't very much information here. So I think we need to know a little bit more detail about the alleged assault. Does she have any other injuries? Has she been cleared of a head and a C-spine injury? This is really important to make sure of, because once that patient is admitted under MaxFax and leaves A&E, if they do have a head or a C-spine injury, that then falls to us to sort out, which isn't very appropriate. We want to know whereabouts on the mandible is the fracture. Because again, depending on whereabouts it is, the management can be quite different. We want to know if this patient has any observations, have they done any bloods for her, and what imaging have they got, because mandibular fractures should have an OPG and a PA mandible. Other facial fractures, so mid-face like zygoma and infraorbital fractures, for those they would take facial bones views, but sometimes they do take facial bones for mandibular fractures and they're not the right ones to look at. So they have given us this patient's observations. So as we can see, her saturation is at 96% and that's normal. Her respiratory rate is 15, again falls within the normal values. Her heart rate is elevated, it's above 100. There's a few reasons for this, which we do go over in some of the other talks. It could be that she is in pain, it could be that she has a heart issue, we don't know, so we're going to need to investigate that a little bit. Her blood pressure is also within a normal range and her temperature is also normal, so no concerns there. So they've got an OPG for us, and so we need a PA mandible as well, and we need to ask them to take this whilst the patient is in A&E. So when you're reviewing the imaging, it's really important to have a systematic structure. I like to start from the top and go downwards. Other people like to start at the peripheries and work inwards. It's whatever works for you. There's some really good articles on Radiopedia going through this imaging, but really the best way to learn how to do this is just to practice. Same with when you were learning how to look at PAs and bite wings as well. So the reason that we always look at the whole image is because even if it's been assessed by someone else, things can be missed. We're all human. And it's really important to know, so the mandible is a ring shape. So that means that when pressure is applied at one side, it does twist. And sometimes it can break on the other side as well. So we often get mandibular fractures in two different places. You can sometimes get isolated parasymphysis or condyle fractures, but you should always, look at the whole image and look to see if there's another possible fracture. So having a look at this, if we start from the top, we can kind of see the outline of the orbital rims. This is not an OPG, should not be used to look at the orbits, but we can see them there. We can then look at the maxillary sinuses. We can see all the upper teeth look grossly intact, but if we look on that right-hand side, you can see that there appears to be a break through the coronoid process of the mandible. And then when we kind of look further down through the mandibular body, sorry, I couldn't actually find a good x-ray, but I've drawn on a left parasymphyseal fracture here. And when we move up to the other side, there's a possibility of a left condylar fracture, but there's a lot of artifact with the C-spine there. So that is why we need that other, the PA mandible to assess that. So this is a different OPG, but I basically just wanted to demonstrate why we need two views. So here's an OPG and you can see that there's a left angle fracture and it looks relatively minimally displaced on there, doesn't it? It doesn't look like it's moved very far. But then if you look at the PA mandible, you can see actually it has displaced quite far. And, it's the perfect example of why we get these two views. Because of the C-spine, it can be quite difficult to see parasymphyseal fractures on the PA mandible, so these are best viewed on the OPG. But we would still assess the whole image though, from top to bottom. So I mentioned when we were looking at the first OPG that the patient had a coronoid process fracture. Now, the zygomatic arch lies directly over the coronoid process. So if you ever see a coronoid fracture, you need to ask for some OM facial bones, because there is a large possibility that the patient has a zygomatic fracture because it's directly over it. So the image on the right-hand side, when we're kind of assessing these facial bones x-rays, that kind of demonstrates what we're looking at. So you can see here we've got the frontal sinuses, we've got the orbit, you can see the nasal and the ethmoid air cells, the maxillary antra, and then they've got the zygomatic complex there as the two elephant trunks. So again, always just have a system for how you want to assess these x-rays, and it will seem a bit overwhelming at first when you get asked to look at them, but over time, when you've seen quite a few, you will know the patterns and things to look at. So if we're looking at the image on the left, this is our patient. So if we start from the top, we can see that the supraorbital rims look intact, and then the infraorbital rims also look fine. On the right, we can see that there is a right zygomatic arch fracture. So if you compare that to the left, you can see where it's disrupted. And if you look at the maxillary sinuses, they're both relatively radiolucent, but usually one of the main signs of a mid-face fracture you will see on the facial bones is a bit of radiolucency in the sinus, because that's fluid or blood. Again, we always have two x-rays taken at slightly different views, and it's the same for the facial bones. So you can see the two views here are taken at 10 and then 30 degrees, so you can properly assess how displaced that zygoma fracture is. So this isn't our patient, but I just wanted to sort of show you an example of what you can kind of see in terms of fluid levels in the sinuses. So if you look at this OM facial bones, and if you look at the left sinus, you can see a very obvious fluid level. And then if you kind of have a look around, if you look at that infraorbital rim, you can see that it's widened compared to the other sign, with a bit of a radiolucent shadow. And that's what we call the teardrop sign. And what that represents is basically orbital tissue herniating through the orbital floor, because this patient has an orbital blowout fracture. And again, hopefully is something that you probably will see. So same with facial swellings. Before we want to launch into a history, we always want to make sure that it's actually safe to take one. So we do a very quick end of the bed assessment. How is this patient looking? Are they clearly in a respiratory distress? Are they actively bleeding? Do we need to jump into an A to E assessment? Or can we take a history? So, same with most of the things, we want to get a timeline of the events, and we want to know what the mechanism of the injury for, and this is important just in case there are other injuries. Has this patient got any potential airway compromise? It's really important that you always remember to ask about the head injury and the C-spine red flags. So all patients should be assessed for a head injury and a C-spine injury by A&E. However, people do miss things. Sometimes patients develop symptoms later on. So it's really important that they're assessed for these things, every time that they are seen. So for head injury red flags, we want to be asking about loss of consciousness, any amnesia, any seizure activity. Has she vomited more than once since the accident? Is her consciousness level dropping? If that were the case, we'd be getting a CT head to look for any intracranial bleeds. If the patient, has any signs of a C-spine red flag, again, you need to speak to A&E. They often advise that you get a couple of different x-rays of the C-spine and speak to orthopedics. And we want to know what the patient's main complaint is. Is it malocclusion? Does she have a visual disturbance? Always important, as you're probably seeing in a lot of these talks, when did they last eat and drink? Because if they need to go to theatre, they need to be nil by mouth. Past medical history and social history and drug history, as always. And for the sake of our case, we're going to say our patient tells you that she smokes 20 a day, she drinks about half a bottle of vodka a day, and she takes cocaine probably around twice a week. She doesn't work, and she's currently sofa surfing. So it's important that we know she doesn't have a fixed abode, is the term that we use for her discharge, because we need to make sure that we're discharging her somewhere safe. So I'm going to take you through the examination of a trauma patient. So as always, we always do the end of the bed inspection, because we're going to do an initial airway check, because we're having a look for any airway compromise. We're going to go over a couple of issues with mandibular fractures that potentially could cause airway compromise in a second. So we want to have a look at the patient generally. Is she bruised? Is there any swelling anywhere? Can you see any open lacerations? Is her mouth obviously propped open or anything like that? Signs of a base of skull injury. So I always do this first so I don't forget to do it. So what you want to do is you want to look for any bruising to the periorbital area. So, around the eyes, the the raccoon eyes as they're frequently called, and have a look behind the ears for any bruising as well. And is there any clear discharge from the nose or the ear? If there's any, signs or symptoms of a base of skull injury, again, you need to discuss that with a senior because that patient will need a CT scan. And then management might be a little bit different because they need to be discussed with neurosurgery. We're then going to palpate the facial bones. So I have something to demonstrate this to you here. So we're, again, having a structure is fine. It doesn't matter how you do it, but I always start from the top and go downwards. So we're going to palpate, and if I had use of both my hands, I'd do this at the same time, and we're going to palpate the supraorbital rims, and you want to compare both sides. You're going to also palpate the lateral orbital rims and the infraorbital rims, and you're feeling for any steps, any crepitus or any mobility. You're going to give it doesn't have very good nasal bones, but we're going to give the nasal bones a bit of a wiggle. And then we're also going to palpate the zygomatic arches. Again, this patient has obviously had a bit of work done, so we're going to feel across the zygomatic arches. You're then going to palpate around the mandible, which I won't do in this skull because it's going to be a bit tricky with the way that I'm holding it. But yeah, you just want to, again, go all the way around, feel for any steps or any crepitus. You then want to check the maxilla for any mobility. Now, the way you do this is you basically get the patient to open the mouth, grab hold of the kind of premaxillar area, and then you probably can't see, but I'm just kind of pushing and pulling it forward. If you see any movement of that midface, that's a sign that patient may have a Le Fort fracture, and again, would need scanning rather than just x-rays. We're then going to, once we've done all of that, the facial bones, we're then going to check the facial movements. So you want to ask the patient to raise their eyebrows, and then squeeze their eyes really tight, and then puff their cheeks out, and then give you a big smile, show you all of their teeth, and that checks all of the facial nerves. You're then, again, going to check the sensation in the distribution of all the branches of the trigeminal nerve, and you want to do an eye examination. So this will be described in a lot more detail later on, but basically what you're looking for is you're looking for any subconjunctival hemorrhage. You want to check the position of the globe, so is one further forward than the other? Is one sunk backwards? Is it downwards, upwards, or sticking out? You want to check the patient's eye movements, and you want to check their pupils are equal and reactive. And you're also going to use a Snellen chart. So I have an app on my phone where I basically just ask the patient to read the letters out. You also want to do something called the medial canthal laxity test. So what that is so if you have a fracture kind of around here to your nasoorbital area, sometimes the medial canthal ligament becomes detached from the bone. So say, for example, if I pull like this, you don't see any movement of the medial canthus, but if that ligament was disrupted, that you would see the eyelids would all move that way that you're pulling. You then want to look up the patient's nose, and you're going to be having a look for a septal hematoma. Again, this is really important because if a patient has a septal hematoma, basically the cartilage can die. So we want to make sure there's nothing like that. And you're going to do an intraoral examination. So we're going to look for trismus, malocclusion, any obvious bruising or hematomas, and any damage to the teeth. So I did say that there was a type of mandibular fracture that can cause airway compromise, and that it's this type. So this isn't the only one, and obviously if you've got a patient with multiple mandibular fractures where that kind of mid-segment is disrupted and is unstable, it would produce the same sort of effect. So basically that segment in the middle is pulled backwards by the genioid muscles, and the tongue can slide backwards and occlude the airway. There is a really easy way to stabilise this fracture, and you can use a bridle wire, which I'll show you on the next slide. This is a bridle wire. It's really easy intervention to do. If you've got a patient with an airway compromising mandibular fracture, it's important to do it for that. But also, if you've got a patient just with a displaced mobile fracture, bridling it will help stop it from moving and will help with their pain control. So what you can do is you can just pop a bit of local in, and you just thread the wire kind of around 2 teeth either side of the fracture, and then you just sort of twist the wire, and it just helps, keeps the ends together. So yeah, really easy to do. And I also mentioned that you need to have a little look up a patient's nose for a septal hematoma. So it's actually really easy to do. You can just kind of thumb the nose up and have a look. So This is very obviously swollen and boggy on either side. The way that this is treated is it's basically incised and drained, and then the nose is packed. So you need to speak to ENT, or if you don't have ENT, you can speak to your senior urgently on site. A&E should be able to deal with this as well. So if you're on nights, you're by yourself, you don't have your MATS/FATS reg and no ENT reg or ENT SHO around to deal with this, an A&E reg should be able to help you with this. So one of the big focuses of this course is we always want you to understand the signs that you are finding on examination and to understand the pathophysiology behind these things, because they may direct you towards further or kind of alternative injuries. So have a think about what are causes of trismus after trauma. Bit different to trismus after infection, like in one of our other talks. But yeah, we want to be thinking about if a patient has trismus, why? What is happening? So possible causes, the most obvious one is pain. If a patient's been punched in the face, the muscles of mastication might go into spasm, they might be a bit bruised, and they're just not working as well. The patient may have a fracture, and especially in an area involving the muscles of mastication, like the angle of the mandible or like near where the coronoid process is, that can easily impinge on one of the muscles and cause the patient not to be able to open properly. As I said, we also have bruising and bleeding to the musculature, and you can also get hemarthrosis and effusions in the TMJ. Right, so going back to our case, what investigations do we need? So we've now got an OPG, we have a PA mandible, and we have the OM facial view. So we know that she also has a fractured right zygoma in addition to that left parasymphysis and the right coronoid process. We want to take some bloods. So for this patient, because she drinks quite a lot, so we want to get an FBC and Usinase, which we would take for any patient. We also want to get some liver function tests to assess her liver function, because if her liver function is off because she drinks quite a lot, we may need to adjust some of the medication doses. We also want to take a coagulation screen. Again, her liver function might not be producing the clotting factors as it should be, so she might be at higher risk of bleeding. So we want to check that. And we also want to check the patient's magnesium. We can take this in something called a bone panel, which we do have a separate talk on interpreting, but a lot of these patients that have alcohol excess are often malnourished, and sometimes their electrolytes can be deranged. They don't heal well, and they have other issues associated with that, so it's really important that we do those investigations and make sure anything is replaced as needed. So we're going to admit this patient, we've sent those bloods off, and we now need to have a little bit of a think about what we need to prescribe. So, are there any special considerations for our patient given her medical and social history? So the mandibular fracture is an open fracture, so she needs IV antibiotics. She also needs some IV fluids because she is still a bit drunk, if you remember from the initial presentation, so we need to rehydrate her. She'll also be nil by mouth, so we want to make sure she doesn't become dehydrated in that time. We'll need to prescribe her some analgesia. She is a smoker, so we should offer her a nicotine patch because smoking reduces blood flow, so it can affect the surgical outcome. Ideally, the patient shouldn't smoke pre-op or post-op. This obviously isn't always possible, but at least if we can help them with a nicotine patch, that will improve their outcomes. We also need to think about putting this patient on the alcohol withdrawal pathway. She does drink quite a significant amount, with half a litre of vodka a day. Alcohol withdrawal can kill, so this is really an essential part of a treatment as well. Other considerations, so this patient is still drunk, so we need to wait for her to sober up a little bit so we can consent her to make sure that consent is valid. She also takes cocaine, so she needs an ECG. Cocaine can cause arrhythmias. It's not that common, but still we do need to check for that, and the anaesthetist will want to see an ECG for this patient. And we need to put her on the alcohol withdrawal pathway, like we said. Because this patient is technically homeless, we need to involve social services quite early so we can make sure that we can discharge her appropriately because we don't technically have a home to discharge her to at the moment. And there is the list of things that we said that we would prescribe and the further investigations that we would get. Just a quick note on alcohol withdrawal. This has come up in quite a few cases, so sorry if you're fed up of seeing this, but it's really important to know about because any patient who has an excess intake of alcohol should be put on this pathway. Alcohol withdrawal can kill, And we do have patients becoming quite unwell from it in hospital quite frequently because this has been missed. So your local guidelines will all vary, but usually you would give a patient something called IV Pabrinex, which is thiamine, it's a vitamin, plus a benzodiazepine that's given depending on, if they're becoming agitated or if they have a tremor or anything like that. Some places also give lorazepam instead. And if your hospital has an alcohol liaison team, it's really important that they're involved because this patient will need help in the community once she's discharged as well. So now moving on to case 2, we've now got Asif, who's a 74-year-old male referred by an A&E consultant. So he has unfortunately tripped over his cat and fallen over in his kitchen, and they've taken some OM facial views and they've said that he has a bilateral fractured zygoma. They've cleared him of a head injury and said that his observations are normal. He has a past medical history of AF, which is atrial fibrillation, hypertension and high cholesterol, for which he takes warfarin, ramipril and a statin. He's allergic to penicillin, he doesn't drink, doesn't smoke, he lives with his wife, and he is a retired accountant. So this is a pretty good handover, but is there anything else that you think you'd like to know? So I know that they've said that his observations are normal, but I would like to know what they are. And I think we should also be getting an INR on this patient as well, because he takes warfarin and he has had some facial trauma. So they've got this OM facial views x-ray. I apologise if it's a little bit fuzzy on your screen. So if we have a look, we'd look at it systematically. If we look at the supraorbital ridges, they look intact. On both sides, it looks like the lateral orbital ridge probably has a fracture through it. They did tell us he had bilateral zygomatic fractures. And we can see the disruption to the zygomatic arches on both sides if you have a look, and possibly the infraorbital rims as well. So this is not, a simple bilateral zygomatic fracture, because actually it means that quite a large proportion of the midface is disrupted, and most likely represents a Lefort fracture actually. So you need to have a little bit of a word with one of the senior doctors, either the A&E reg or your MaxFax reg, because you're going to need a CT head and facial bones to see the extent of that injury. So just a little bit on Lefort fractures, and they're not particularly common, but it is fairly like that, you would see at least one across the year. So this image is just a very basic visual representation of Lefort's and like the bones that they're going through. So the Lefort one, which is in image A, so that's a horizontal fracture and it separates the teeth from the midface basically. The fracture line passes through the alveolar ridge, your lateral nose and the inferior wall of the maxillary sinuses. The Lefort 2 fracture is a pyramidal fracture, so it's kind of like an upside down triangle. And that fracture passes through the posterior alveolar ridge, the lateral walls of the maxillary sinuses, your infraorbital rims and your nasal bones. Because of the infraorbital rim involvement, these patients often have numbness of the cheeks because the V2 is disrupted. The Lefort 3, so this is basically, kind of disruption of, you basically detached your face from the rest of the skull. So the fractures extend through the nasal bridge, the medial orbital wall, the posterior orbital wall, and the lateral orbital wall near where that frontozygomatic suture is, and the zygomatic arch is nearly always fractured as well. So with Lefort 2s and Lefort 3s, there is a risk of retrobulbar hemorrhage, which we'll go over, and Lefort 3 has a higher risk of a base of skull fracture, and that's why it's really important that we need that CT scan. So your approach to taking the history is the same as always with the trauma patients, and this is exactly the same as what we had before. Always remember to take the history of the head injury and the C-spine injury red flags, because especially this patient actually has more of an extensive injury than what we originally thought. We also want to check if the patient has a recent INR, and he said, yes, I had it done when I came in and it was 3.2, and you have a look on the computer and you can see it. So we think our patient likely has some sort of Lefort fracture. So what are the important signs that we may see here? Because remember, this is more extensive, could be extending intracranially, patient could have a base of skull fracture. So, we want to be checking for those signs of a base of skull fracture, which are the raccoon eyes and the postauricular bruising and any clear fluid coming from the nose or the ears. If the patient has a base of skull fracture, it's always really important to remember they cannot have anything up the nose. So they can't have any nasal packs if they've got a nosebleed. They can't have an NG tube. They can't have a nasal tube if they're to be put to sleep for a GA either, because there is a possibility that the tube could go upwards and straight into the brain. The patient will likely have mobility of that midface, and when you look at the patient's eyes, you might see some subconjunctival hemorrhage. They may have a reduced range of eye movement, so they might not be able to look upwards if things are herniating through the orbital floor. The patient may, when I said about that medial Canthon laxity test, they may have laxity of that because they may have a nasoorbital ethmoid fracture. They may be bleeding from their nose. If it's not stopping with simple measures, it's really important to call ENT, because if you don't know how to stop that nosebleed, and if A&E can't, it kind of depends on where you work in A&E. Some A&Es will manage epistaxis, some do not. But as long as there's no base of skull fracture, the patient can have a nasal pack. But if they do have a base of skull fracture, then no. And the patient may have a deranged occlusion or some intraoral bleeding. So those are the important things that we're going to be looking for with the examination of this patient. But as always, we do the full examination for every single patient just to make sure that we don't miss anything. So the ability to do a thorough eye examination and understand what you're seeing is so important, because you may be able to save someone's sight if you pick up on some of these things early. So the first thing that we look at is the position of the globe, and I've now got some pictures to demonstrate what the names of the different positions are and what's happening. So when we look at the position of the globe, we have a look kind of from the sides and from above. So we're looking at this patient from above, and she has what we call enophthalmos. So that is the posterior or the backwards displacement of the globe due to loss of volume from a blowout fracture. Another thing you might see in patients with infraorbital blowout fractures is hypoglobus. So that's the inferior, so the downwards displacement of the globe, again due to loss of volume from a blowout fracture. So if you look at this picture, you can see I've drawn a line through the pupils, and you can see that one is quite clearly sinking as opposed to the other one. Here's another demonstration of hypoglobus. Again, a bit more of an extreme example, but it demonstrates it quite nicely. Exophthalmos, very, very important sign, because it's the anterior displacement, so the forwards displacement of the globe due to an increase in volume of the orbit. In this context, it's likely going to be bleeding. Why is potential bleeding inside the orbit important? So it's important because it's a sign of a retrobulbar hemorrhage, and this is an emergency because patients can lose their sight. So the signs of a retrobulbar hemorrhage, I want you to remember all of these P's. So it's pain, which is in or behind the eye. Proptosis, so the eye is displaced forward. It might be difficult to see in patients with really swollen and bruised eyelids, but that's why it's so important that you do need to open those eyelids even if they are swollen shut. The patient may have reduced visual acuity, and they might also lose the red colour vision, and this is due to irritation of the optic nerve. Like I said, it is an emergency and it's sight-threatening. So if you spot any of these signs, you absolutely must call for help immediately. If your own registrar isn't on site and you don't have ophthalmology, A&E registrars should be able to do the treatment for this, which is a lateral canthotomy, which we'll talk about in a second. So here's a CT scan, demonstrating what you can kind of see if a patient is having a retrobulbar hemorrhage. So if you look on the normal side, you can see that there is, it's black behind the globe, and then if you look on the side where the eyeball is clearly sticking forwards, all of that grey stuff is blood. So the reason that you get the examination signs that you see is because the optic nerve comes out the back of the eye and it's being compressed by blood. So it takes information about light back to the brain, and it activates the other nerve, so the oculomotor nerve, to construct the pupils. So if that nerve is being compressed or irritated by blood, it's not going to carry the signal, and that's why the pupil doesn't contract when light is shone in. And it's also why you can't see one of the other things that you lose is the ability to see the colour red. So I have something that's red on my badge, so I always ask the patient, what colour is this? And if they say it's pink, then we know that that is a problem. The treatment for this is a lateral canthotomy by a senior, so A&E registrar, MATSVATS reg, or an ophthalmology reg. And it doesn't sound very nice, but you basically cut open the lateral canthus under local anaesthetic, and you release the superior and inferior tendons as well to release the blood. Things that you can be doing whilst you're waiting for someone to come and help you with this is you can give the patient a medication called acetazolamide, because that can help reduce some of the intraorbital pressure, but it is contraindicated in certain patients, so I would always have a look at the BNF and I would speak to someone before you start that. So any abnormal pupil reaction or no reaction, or any reduction in visual acuity, you have to discuss it with someone, because it could be a very early sign, even if you don't have that proptosis yet, that there is a bit of a bleed going on behind the eye. And going into a bit more depth about pupillary responses, so what can you see here? So we're looking at what seems to be a child, and her left pupil is much bigger than her right one. So some of the reasons behind this, like I said, if you spot this, you do need to discuss it. It can be normal, it can be physiological, it's called an isochoria. Like I said, the patient's pupil might not be constricting due to an optic nerve issue. So, retrobulbar hemorrhage in the context of an infection could be orbital cellulitis, which is irritating the optic nerve. And sometimes patients who have neurological issues such as MS can also have this. There is also, and I hope you would never see this, if patients are having large intracranial bleeds, you can also get this blown pupil due to an oculomotor nerve compression, but those patients would often be unconscious and certainly not for you to manage. So again, here is a demonstration of what should happen when you shine a light into a patient's eye. So when you shine the light, the pupil that you're shining it into should constrict, but the other one should also constrict. If you have one pupil that's not constricting, you can't tell which the abnormal one is. It's basically the one like that. So you can see here in the third picture, this patient has the afferent pupillary defect of the right eye because you shone it into that one and the other pupil isn't constricting because there is no signal going from the optic nerve because it's being irritated by something. So when you're checking your patient's visual acuity, make sure you know where you're supposed to be holding your chart. So a lot of them will say 6 feet, 4 feet. Like I said, I use an app on my phone. It's a 4-foot one. And make sure you're standing roughly 4 feet away from the patient. If the patient ordinarily wears glasses, please ask them to put them on because you don't want to be thinking that they've got reduced visual acuity, but actually, it's just because they don't have their glasses on. So we deviated a bit now, but going back to our case, so this is where we're at now. So Asif was a 72-year-old male. He attended A&E after a fall, and we found after some investigations that he had a Lefort 2 fracture. He's on warfarin and unfortunately had a retrobulbar hemorrhage, and he had a lateral canthotomy in A&E for that. So not all patients with a Lefort 2 necessarily need admission unless we suspect they have a head injury, because he might not necessarily need surgery for it depending on how mobile it is, but he did have a lateral canthotomy and he's on warfarin, so he really should be observed. So we need to have a little bit of a think about what we're going to prescribe. So we want to give him some analgesia. He's obviously going to be in pain. We can give him some paracetamol, some codeine or Oromorph. Really important to prescribe some laxatives such as Senna or Docusate with that because any opioid can cause constipation, especially in an older patient. Check your local guidelines as to whether or not we would give any antibiotics. Ordinarily we wouldn't with this because it's technically a closed fracture. And any sort of special considerations for this patient. So he's on warfarin, we need to take his INR regularly, and he also needs, because he's had this retrobulbar hemorrhage, he needs an ophthalmology review, especially if he's due to go for surgery for the ORIF of his Lefort. So when we're admitting Asif, these are the sorts of things we want to be prescribing and thinking about. So as we said, we want to discuss his warfarin with A&E and haematology. Do we want to think about reversing it? You don't always reverse an INR that's less than 5, but he has had a bleed and now has an open wound. So it might be worth giving him a bit of vitamin K. But again, that would be something to discuss with your seniors. We also want an ophthalmology or an orthotics review as soon as possible because we need a baseline of his visual acuity and his eye movements and everything. He's on ramipril, if you remember, so if he needs to go to theatre, we'd hold that the morning of the surgery. And we also need to advise him not to blow his nose, and if he needs to sneeze with his mouth open, because that will help prevent blowing air up into the area and preventing surgical emphysema. And we're on to the last case now. So now you are referred a child from Peds A&E, and we've got Annabelle, who's an 8-year-old female, and she's fallen off a bike and has a laceration to her left cheek. A&E are admitting her under paediatrics because they're suspecting a head injury because the patient's been vomiting quite a bit, and they're awaiting a CT head. She's otherwise fit and well, and her current observations are, again, I apologise that they are hidden behind my recording, but her temperature is 36.5, which is normal. Her respiratory rate is 24. Her oxygen saturations are 97% on room air. Her BP is 100/65, and her heart rate is 44 beats per minute. Now, 8-year-olds have a slightly different observations, like a normal range as to what adults do. So again, all of these are input onto a system that will tell you whether or not they are normal. But the main thing that I can tell you that is abnormal is her heart rate. Usually at that age, their heart rate has a higher normal range than what an adult would do. So that is quite low. So our main concerns here are that we have a child who has potential head injury. I know they've just asked us to just come and suture a laceration, but it is important that we do a full trauma assessment here. So, your history taking is largely the same as with an adult, except there's just a couple of different things. So when we're taking a child's past medical history, it's always really important to ask about vaccinations and any other sort of childhood illnesses. Social history as well is a little bit different. We don't expect 8-year-olds to be smoking and drinking. I mean, they may do, so it could be worth asking. But yeah, so we'll be asking, who's at home with them, what year are they at school, is there any sort of social care involvement as well. Your examination is exactly the same as in an adult. However, she is a kid, so you may need to employ some of those behavioural management skills in order to do a couple of these bits and pieces. But again, it's really important that you do it in a set structure and you do check everything. So we can see here that Annabelle, she's got this right cheek laceration, and it doesn't look particularly exciting. It's not really bleeding that much. If you have a look at the facial wounds talk, you'll see that it's kind of not within the danger area that we would be concerned over the facial nerve or the parotid duct. However, we've already checked those things anyway. So what else would you like to examine? As I said before, all patients, doesn't matter if it's just a laceration, should have a full trauma examination. And when you're doing your trauma examination, you do an eye examination. And this is what you notice when you're checking her eye movements. So you can see here, her left eye, she's looked up and it's fine. The right eye isn't going up. Hopefully, none of you will see this. It's incredibly rare, but I thought it was very important to include as an aspect to be aware of what we call the white-eyed blowout fracture. So this is, it tends to happen more in children. However, it can sometimes happen in young adults. And basically what happens is this patient, she has an orbital blowout fracture. But because she's so young, the bone is quite sort of spongy. So if I, say, had some trauma to my eye and my orbital floor blew out, the bone would just break and it would just go like that and everything would herniate through. In a child, the bone breaks. The things may herniate through, but because it's spongy, it just snaps back up and it traps everything. So that's why she has this restricted eye movement. And it's not always just the inferior rectus. Depending on which muscle is trapped, it could also be the medial rectus if it's the medial wall that's broken. But these patients don't tend to have any subconjunctival hemorrhage, so it's not always obvious that they have an eye, an orbital fracture or anything. It's a really important thing to pick up on because it's often mistaken for a head injury by A&E because they will be vomiting, and sometimes the CT scan doesn't always reach the orbital floor. So if they take a CT head, they won't see the orbital floor fracture, and it won't be until that restricted gaze is noted that anything is kind of flagged up about it. So we've got CT scans here in both a child at the top and an adult at the bottom, just to demonstrate what I was saying about how the bone behaves. So yeah, like I said, in children, it's springy, and so it's a bit like a trapdoor where it will spring back up and it's trapped to the inferior rectus, and that's what you can see on that CT scan. Whereas in the adult, it's, blown out and everything's fallen through it. Because you have bone trapping muscle there, that muscle's at really high risk of necrosis, so it usually needs operating on within 48 hours. So identification is the key here. And like I said, it's not always in children. We fairly recently had a patient actually who was in her early 20s. But the main kind of triad of these symptoms is that restricted eye movement. The patient will be vomiting and their heart rate will be low. And that's because of what we call the ocular cardiac reflex, which I'll just explain on the next slide. So when you get this type of blowout fracture, the reason that you also get the vomiting and the slow heart rate, the bradycardia, is because the pressure on the extraocular muscles of the orbit is sensed by your trigeminal nerve, V1. So some signals are transmitted in the central nervous system to the motor limb of the vagus nerve because the fibers cross over, and that's what causes the bradycardia and the nausea and the vomiting. But like I said, it's very often mistaken as a head injury because it's vomiting. So it's really important that if you spot something like that and you see that bradycardia, you're looking for that reduced eye movement because, again, if that muscle undergoes necrosis, that patient could have like a lifelong visual impairment. So some important take-home messages when assessing your trauma patients. Always ask about signs of head and C-spine injury. Don't assume that, everything is fine because they've been seen by A&E, because things do get missed. And once the patient is admitted under us, we would then have to, assess and manage those issues, and that's not very appropriate. Always carry out your examination in a systematic manner. So, similar to the A to E assessment, always be checking for the same things so you don't miss anything. And the eye examination is really important. And if you're in doubt and if you spot any form of abnormality, it's really important that you inform someone. It might be nothing, but it could also be a sign of something that's going on that, could cause a real problem. So here's some further reading for you. Two really brilliant websites, Radiopedia and the Radiology Masterclass, will have they've got some really good articles and ways to help you interpret facial bones x-rays and any sort of imaging really that you might want to look at. Pocket Dentistry has some really good articles on facial trauma, as does the eFace modules on the e-learning for health. The AOCMF, that kind of is more a bit about how to kind of manage fractures and things, but again, it would be interesting for you guys to read. And the SHO-Me app is it's an app and it will go through how to assess all these trauma patients on your phone. So that's the end. Thanks again for listening to this talk, and any issues, any questions that you have, please don't hesitate to email us. If you'd like to leave us any feedback as well, please fill out the feedback form. We'd be really grateful to know if there's anything that we can do to improve this for next year.